I'm starting the recording. Okay. I'm just admitting some more people. Okay. So hi everyone. Sorry about that. My name's Olivia and I'm the unit coordinator for this. But if that whole start wasn't a hint for you, this is my first time lecturing at QUT. So you are going to have to do what you just did and help me out if I need it. But I'm very excited to have you all here, and I'm very excited to share all your expertise, both in nursing and technical issues. It's very much appreciated. Now, I'm just going to, there we go. I've now figured it all out. So I'm going to start by acknowledging the traditional owners of the land where QUT now stands, which is the Turrbal and Yagara people, and pay respect to their elders, past, present and emerging, and also acknowledge that the lands here have always been places of teaching, research and learning, and that Aboriginal and Torres Strait Islander people continue to play an important role in the life of all of us here at QUT. So, can you see the screen that's got the acknowledgement on it? Yep, okay.
Yes.
Okay, so just a brief overview of what we'll be covering today. We are going to be covering mainly around our first module of this unit, which is around chronic disease multimorbidity, from an Australian perspective mainly, but also talking if we've got people from overseas as well. We're going to look at the relationships between chronic conditions in terms of causes and risk factors, and we're also going to look at the burdens of multimorbidity. And we are going to generally discuss sort of issues in chronic disease management, and then we're going to just end with an example of an integrated chronic disease nurse practitioner clinic, just as something to get us all excited about this topic. And then we will talk a little bit about person-centred care, and then if we get time at the end, we'll talk about assessment 1. I'd like to do that if we can. So this is our little intro to Zoom. So some of you will have had experience with Zoom, but some of you not so much. So have a look here. This little button, mute on the left-hand side, just encourage you to mute your microphone if you're not speaking, just because of the background noise, and I may have a little bit of background noise, I apologise. If you want to say something, then unmute, totally fine. I encourage interaction, it's really, really helpful. If you want to be called something different than what your Zoom name comes up as, then you click on the participants there and you get little options next to your name, and you can change what comes up on the screen. And I really strongly encourage everyone to post comments in the chat. I'll give you opportunities throughout the webinar to sort of share your thoughts, and we'll spend a little bit of time going through those together, because I think that we have such a diversity of experience between us that we can learn more from each other than we can from just listening to me go on and on by myself. So that in mind, my name, this is just a little bit of a slide about me. My name's Olivia, as you know. My background is in mainly oncology, haematology, but also some other areas of nursing care. I have recently, well, a few years ago, I did a master's in public health, and just recently completed a PhD in public health. And in that, I actually looked at working with people recently diagnosed with HIV here in Queensland. And HIV is an example of a condition that once was life-limiting and is now very much a chronic condition. And so that really, along with other areas I've worked in like oncology and inherited bleeding disorders, really has got me interested in chronic care nursing. And then I've also, like in terms of my teaching, although I'm new to QUT, I have had some teaching experience in public health when I was previously a PhD student. So that's me. So just to give you a brief overview of what's involved in this unit, there are 3 modules. They're self-directed modules with sort of reading and learning activities throughout. And what I've tried to do when I updated the modules was actually give you lots of articles to look at, but give you key little directions. So when you read that article, something to think about, because sometimes just reading lots and lots of articles can be a little bit overwhelming, too much info. So have a look at the module and actually look at what it is you're meant to be kind of getting out of that particular article. There are 3 seminars which are designed to consolidate your learning from each of the modules. So we'll give you some pointers on where to go with the modules. They're actually in weeks 1, 4 and 11. I think in my welcome email I said that it was in week 9. I think that was just wishful thinking on my part. It's actually in week 11. So quite a long break between our 2nd and 3rd times that we will meet like this, but that's okay. There are 2 assessment tasks, as I'm sure you've probably had a look. An evidence review due in week 6 and a case study due in week 13. I think that's everything I wanted to say. Oh, in terms of the assessments, what I've done on Blackboard is in the assessments tab, I've posted a bunch of resources. If people are new-ish to postgraduate study and you want to just get a little bit more of an idea of what's kind of expected in terms of the writing and that, then there are lots of resources there, because QUT does all of that stuff on a regular basis. And so there's sort of self-directed modules, or there's workshops, or there's one-on-one options if you need that extra support with your writing. So the 3 modules, essentially today's, we are sort of around the impact of multi-morbidity. Then the second one looks at strengths and symptoms, and the 3rd one looks at complex care models in nursing. For your assessment task 1, the evidence review, you really just need this first module to be able to address that assessment. So I inherited this course when I started here at QUT a couple of months ago, or this unit, I should say. And so if there are things that you think could be done differently or presented better, or things that should be included or not included, I really encourage you to get in touch and give me feedback, respectfully, of course. But, you know, as I said, I'm new to this, so I'm really interested in how it all goes and what your perceptions of the unit are. So just super briefly, before we get into what we're actually going to talk about today, this slide is about pathways for nursing education. This particularly relates to QUT. So there may be people who are particularly interested in sort of advancing their nursing in terms of either practice or research. And so what happens there is where you are is either currently in the blue graduate certificate in nursing, or perhaps some of you are in the Master of Advanced Practice Nursing, or some might be in the Master of Nursing Science Nurse Practitioner. So they're the ways, like, so if you've got a grad cert, then that leads you to go on to then perhaps do a master if that's what you're interested in. And the master has 2 different streams You can specialise in an area of practice, or you can specialise in research, which we call a dissertation masters. And if you do that, then that makes you eligible to do a PhD. So, you know, just something to think about. But that slide was in there when I got this unit, and I thought, it's actually good to know that, because a few of you have expressed interest in actually doing further study, and there are heaps of different ways you can do it. There's no prescribed one way of going about doing further study in nursing, so it's good to know. So I think I'll move on to where we're going. So basically, we're going to be talking today about chronic disease multimorbidity. And so if you can, for me, it would be great. In the chat, if you click on the chat and just write in there, why do you think, just a couple of words or a phrase, why do you think we are seeing such a rise in chronic conditions and therefore multimorbidity? Just type in a reason or two why you see that we're getting more and more people experiencing. Yep, so, okay, some things are starting to come in. So we've got people saying that there's an ageing population and people are living longer. So absolutely, that is absolutely. So we've got lifestyle factors. Yep, we've got a public health gap. Yep, and people's lifestyles have slowed down or they're very stressed. So yep, so we're talking a lot about the lifestyles that we're leading. Access to healthcare, absolutely. Yep, living style factors. What do we mean by lifestyle factors? What are we talking about? Oh yeah, cultural issues. Yep. What are we talking about? Putting there in that chat. What do you mean by lifestyle issues? Oh, yep. Awesome. You guys are great. There's so much coming in. It's really good. So make sure you. So we've got something Leanne put in, which is fantastic. Early diagnosis. Absolutely. We are actually diagnosing stuff earlier, which means that people are actually able to have better outcomes. They live longer. Yep, so we've got, in terms of lifestyle, we've got technology, we've got sitting down on computers, games, TV, absolutely. We're more sedentary. We've got more stresses. We're working longer hours. People are dealing with the economy, shifts in the economy. We've got diet, exercise. Yep, a lot of us not doing quite enough exercise and not eating quite enough fruit and vegetable. We're eating lots of fast food. Yeah, we've got a society where we love to eat out or have takeaway and less sort of home cooking. Yeah. Yeah, and as Chloe said, it'll be interesting to see if these factors will be impacted by COVID and the fact that we're more and more working from home. Yep, aging, stressful life stress. Shift working nurses, yeah. So everyone's put in some really great ideas, so thank you very much. What's really great about your responses is that you're already thinking critically, and that's so important in postgraduate study, and as practicing nurses and advanced practicing nurses. What we're doing is we're not just accepting that there's one answer to this question of why. We're seeing a rise in chronic conditions. We're acknowledging that there are many factors involved, and that's what the basis of critical thinking is. Not just accepting one answer, looking at all the possibilities, and actually then forming an informed position on that issue based on your knowledge of these different ideas. So it's really good to see that already you're doing that. That's fantastic. So on my slide, chronic disease multimorbidity is simply the presence of two or more chronic diseases or conditions within the one person. And so the presence of these multiple chronic diseases is associated with a decline in health outcomes, health-related quality of life, mobility and functional ability. It's actually associated with an increase in hospitalisation, psychological distress, mortality and use of healthcare resources, and a loss of productivity, including the ability to work. So what this is adding up to is that we actually do have a significant public health issue, which is chronic disease and comorbidity. It is impacted by all the factors that we've talked about, so ageing populations and all these other lifestyle factors. It's just the way we're heading. And so as nurses, I strongly believe that we are absolutely imperative as a workforce in dealing with this growing public health concern. And I think the reason I can sort of say that with real confidence is even just looking at the Padlet, just for the people who have sort of introduced themselves, the breadth of experience across that group. And so there's probably only about 12 on there at the moment, but we've got primary nurses, we've got people working in acute care, people working in aged care, people working in rural areas, outpatients, inpatients, somebody working in justice health, in the sort of prison and corrections setting. And so when you look at that breadth of experience and roles where nurses exist, our ability to impact this issue is massive because we have the reach. We are in every facet of the health system. And so what we're about in this unit is really looking at ways that we as individuals and along with our colleagues, we can actually impact this significant public health issue. So I'm just going to go forward a slide. So in the Australian context, and this is from the Australian Institute of Health and Welfare stats, these are the sort of top 12, if you like, chronic conditions that are affecting Australians. And so is there any on there that kind of surprise you, or are they all kind of like, yep, that makes sense? Just pop in the chat if there's any that stick out. Yep, a few people are saying oral disease. Yeah, it does stick out a bit because you don't, I didn't sort of think of that. I sort of thought more like heart disease, cancer. Yeah. What do you think it is about oral disease? Can anyone have a go at saying why that might be an issue? Yeah, it's far-reaching. Yeah. So where everyone's got teeth, yes. And yeah, so inflammation cascade. So poor teeth is actually an indicator of poor health, and vice versa. So it is linked. And yeah, and changing lifestyle factors. So, you know, with an increase of sugar and all that, then yeah, maybe that does translate to, you know, some earlier oral hygiene problems. But, you know, we are doing a lot better than we were, say, 50 years ago. But also in Australia, yeah, absolutely, Leanne said, it's the last thing we spend money on. And we are compelled to spend money on it because there isn't really a universal dentistry system here in Australia. It is sort of like pay for service. There isn't really a universal system. So yeah, we need better Medicare for dentistry. Yeah. So yeah. And people have also said that colon or like colorectal cancer is an interesting one too. And I think that's an example of one of those diseases that perhaps once was more life-limiting, but with sort of universal screening of 50-year-olds and above, we're sort of intervening earlier with that. And maybe with our lifestyles, you know, we're sort of more at risk of colorectal cancer, but we are also catching it earlier. So people aren't necessarily dying from that, but they're living with it long term, and all of the sort of complex manifestations of something like colorectal cancer. So I'm just with this is some this document, Australia's Health. I've put that in as a link on module 1. It teaches us lots of interesting statistics about ourselves and about our population. So basically, older Australians who are living with arthritis, 50% of those also had hypertension, 20% had cardiac disease, and 14% had type 2 diabetes. And older Australians, and I think we're talking plus 65, so not that old, 60% of older Australians living with asthma, 60% also had arthritis, 20% had cardiac disease, and 16% had diabetes. So we are seeing numbers of people living with multiple chronic conditions going up. So this is from the National Health Survey. So this is actually the survey that informs the statistics that were on the previous slide. So that Australia's Health, they do this National Health Survey every couple of years. And if you look, let's see if this will work. So in the age group sort of 45 to 64, we have 30% of people are living with one chronic condition, and 14% are living with two chronic conditions. So we're not talking about people that are that old. And then if you go over to the 65 plus group, those numbers go up. So we've got down here, we've got only less than 20% of that population are living with no chronic conditions. So the vast majority of the population of people over the age of 65 are living with at least one chronic condition. So we are absolutely seeing these people coming through our healthcare settings, no matter what setting that we're in, whether it be emergency, aged care. That this is something that we as nurses were sort of compelled to address. So this is actually not just an issue in Australia. This is a global issue. And so I don't know whether we have any people from other countries who are joining us now, but it'd be really nice to know if you could pop in the chat if you have some insight. Is this something that you also see in your country's context? And I would imagine that there would be some similarities only because you're here, so it's interesting to you. But yeah, does anyone want to put anything in the chat about other country contexts? Anyone who's got experience? I just put on the screen there, this is just like a tiny sample of the papers that are out there about multimorbidity. And as you can see, there's ones from Europe, Southeast Asia, the US. And so we're not just, this is a global public health issue. What sort of things? Well, I'll probably, I think, globally, we've got countries that are at different levels of development. So we've got sort of high income countries and lower income countries. We have increasingly begun to address some of the things like maternal and child health, immunisation, and sort of communicable diseases or infectious diseases. And so people are living longer, no matter the context. And so this, I guess the point I'm trying to get at is that what's happening here in Australia is something that is also even countries with like a lower income country are starting to see these issues as well. So it's a positive thing that we're addressing we're able to address many diseases, but as a result, we have more and more people living with chronic diseases. So this just is just another way of looking at what I already sort of talked about, and this one's in your module as well. It's just a little graph, and so really just saying that where, you know, see the pink section is people living with 3 or more chronic conditions, and so it's actually a pretty good chunk of the population. And so as we increase our technologies and we get better at treating diseases, then I would imagine that pink section on the right would start to get bigger. And it's not necessarily a bad thing, but what it means is that we've got people living lives in the context of complex health issues. So part of the module is about how diseases occur together and why. And this is actually in the first part of your assessment. You need to have, of your evidence review, when you choose 2 conditions that you want to focus on, you need to have a think about what it is about those diseases that's making them happen together, and critically analyse that. So there is some content in the module about this, and so we'll just go over that a little bit now. And so we've essentially, on this slide, there's kind of 3 categories that we might be able to use to account for the coexistence of more than one disease in one person. And it's a branch of scientific research that considers the etiology or cause of comorbidity. And so we can have simple sort of co-occurring diseases, which could actually be a coincidence. There may not be any link. So something like, I was trying to think of an example, I thought maybe bowel cancer and dementia. These 2 diseases are not necessarily linked, but they could occur in the same person. And then we have associative, where these 2 diseases are known to frequently exist together, and they may be linked in terms of risk factors. But the physical or causal pathways may still be unclear, or in fact non-existent. So I thought maybe something like cancer and depression. And then we have associative, which is sort of known, causal, which is something like diabetes and chronic kidney disease. So we have a build-up of glucose in small vessels of the kidney, which causes damage, which causes renal failure. So same with something like chronic obstructive pulmonary disease and lung cancer. You have a risk factor which links the 2 of them very clearly, which is smoking. So that comes from an article called Valderas et al. And this is also in your module, this particular little diagram, and it just goes through a little bit more detail on that discussion. So it's going to be quite important for you to sort of have a go at this in terms of your 2 diseases and try and see where they fit. So we have on Valderas's model here, it talks about no etiological association or no cause, diseases that have no association, no causal association. And then you have direct causation, where one of the diseases may cause the other, and they use the example of diabetes and cataracts. And then you have associated risk factors. So risk factor for each disease are correlated. So the risk factor of smoking and the risk factor of alcohol can contribute to diagnosis of COPD and liver cirrhosis. And then they also use the example of heterogeneity, where the risk factors for the disease are not related to each other or correlated, but each one of them could cause either disease. So, for example, risk factor 1, smoking, risk factor 2, age, diagnosis 1, ischemic heart disease, and diagnosis 2, lung cancer. So smoking could cause ischemic heart disease, or it could cause lung cancer or be associated with. And same as age, could be associated with ischemic heart disease or lung cancer, with or without the presence of the other risk factor. So, and then finally, independence. So this is where diagnostic features present for each disease are actually due to a third distinct disease. And they give an example of pheochromocytoma, which I had to look up. It's actually a rare adrenal gland tumour, but you've got hypertension and tension headaches, and it turns out that they're both actually caused by this third thing that's going on in the background. So there's actually, this is a constantly emerging science. So I want you to have a go at this, but there's going to be, it may be that the answer is more than one. So have a go, critically look at it and see if you can work with the two diseases that you choose, and offer some suggestions as to why, based on the evidence that you find they may co-occur. Now we've got a, Leanne's asking if it's idiopathic, and yeah, so that if you choose something that's idiopathic, then yeah, absolutely. Do you mean like it's the body's causing it to itself? So like an immune disease or something? Yeah, so look, that is absolutely like, I mean, I think immune diseases are really like lupus or something like that. Yeah, they are a legitimate type of chronic disease that you may wish to discuss. But then, yeah, so from virus to end-stage renal disease. Yeah, so I think if you're going to discuss those two diseases together, that makes sense. And yeah, just outline that kind of causal or etiological pathway. Hope that makes sense. I'll answer more questions about assessment later if I get a chance. So here we have an example of 3 diseases that that are often known or associated with each other. They are well known to occur together. So cardiovascular disease, diabetes, and chronic kidney disease. And so what we have is we have shared risk factors within those 3 diseases. So atherosclerosis, hypertension, and shared risk factors. Now, some of those shared risk factors might be smoking, high sugar diet, and then you get the sort of complex interplay where the risk factors contribute to the presentation of those 3 diseases together, but then also the diseases contribute to each other. So something like hypertension, which is associated with cardiovascular disease, then can perhaps impact people then developing chronic kidney disease. And then like with the high blood glucose, again, that's associated with diabetes, but then it becomes also associated with chronic kidney disease. So so it's just a matter of thinking about the sort of the science or the clinical picture behind these comorbidities. And that's just a good example, that 3-way, like those 3 often present together. And we'll talk about them a little bit more later when we talk about the integrated nurse practitioner model. We, after delving into clinical and causal pathways, we also have this great big social picture that's going on around that, those sort of clinical or what's going on in the person, and with their own body systems. And so a social model of health, in fact, it's in the social side of things where the true complexity may lie. And so it's really important to consider also, alongside all this sort of etiology and causal pathways and risk factors, the social drivers that underpin multimorbidity. And so these include things like economic climate, political climate, cultural factors, the environment, and our behaviours, our health behaviours. And so these factors actually impact the way diseases can be managed, but also impact the burden that they have on individuals and families and community. And so it's really important for us as nurses, we are sort of somewhat uniquely positioned across this interface between clinical aspects of care and also social aspects of care. And so we really understand that for treatments to be successful, especially in the long term, they must be integrated into people's everyday and social lives. And so we are ever mindful of the social as nurses. And so it's important that we, when we come into this unit and we're learning about chronic disease, we don't get too fixated on the biomedical understanding of health, which could lead us to think that all we have to do to make someone healthy is eliminate their disease. We all know that there's more to it than that. And so if you've seen the WHO or the World Health Organization's definition of health, it's not about the absence of disease. It's about the emotional and social well-being and cultural well-being as well. And I think we really need to reflect that people's social circumstances, many of which are beyond their control, can impact both their health status and their access to health services. And not everyone has equal opportunities to make healthy choices. So I want you to consider, if you can see on that slide, you've got the yellow economic environment, the physical environment and social environment. Now, these are all determinants of health. And the one in green is the lifestyle and behaviour determinants of health. So can you, in the chat, just quickly, and I know that you cover this stuff off in the healthcare context and service provision. If you're doing that module or you have done that module, then you will be covering this stuff off. But I want you to put into the chat box, can you give me an example of a health behaviour? What your understanding of a health behaviour? Something that you might encourage patients to do. We've got exercise, yep. That's a good one. Healthy diet with less sugar, yep. Eat well, definitely, yep. Exercise, yeah, a couple of people saying exercise. What else? What should we do less of? Oh yeah, vaccinations, that's good. Yep, less smoking. Yep. Yep, education, yep. Educating our patients. Yep, well that's something we should do more of, but yep, decrease alcohol, yep, definitely. People are going, yep, definitely decrease alcohol, yep. So yeah, so we're really good. We know what it takes to be healthy. As nurses, we are very cognizant, or we have that knowledge, and we are very able to share it with our patients. We do know what will help them to be the healthiest that they can be. But when you look at the yellow, blue, and pink sections of that circle, they're the complications. They're all the reasons why it's sometimes hard for people to take our advice. It's even hard for us to take our own advice. So can you maybe, this is just for a challenge, in the social environment, it says discrimination. Can someone have a go at putting in the chat why you think discrimination might impact some of those health behaviours we just talked about? So drinking, eating right. It's a bit of a stretch, but have a go. Peer pressure, yep. Yeah, peer pressure, absolutely. For drinking and smoking, definitely. We know that's an impact. Yep, cultural norms, definitely. So cultural norms around some of these health behaviours, if we come from a family where we have big meals and we eat and that's how we connect, then yeah, we're not going to be very interested in anyone's advice around you know, portion controlled salads. Okay. Yep, so Gemma said that discrimination can lead to a low mood using food or alcohol as a coping mechanism. Yeah, absolutely. Yep, and Leanne has said the cost of fresh food in the outback. Absolutely. So where we are positioned in terms of our access to the things that we know are good for us makes a big difference. And financial cost of being healthy is a thing. We know that. There's a lot of evidence to support that, you know, junk food's easier to get and cheaper than healthy food. I went out to the shops last night with my daughter who's 14 and she found 3 cheese pizzas for $6, and it wasn't a 3 cheese pizza for $6, it was 3 cheese pizzas for $6, and you can't argue with those prices. And we've got here, yep, so Penal said that discrimination can lead to mental health issues. Yep, absolutely. And that then impacts health behaviours, particularly something like risk-taking behaviours. And Chloe said Aboriginal and Torres Strait Islander populations and closing the gap and health priorities. Yeah, and so we do know in Australia that Aboriginal and Torres Strait Islander people do experience less optimal health outcomes than some other population groups, and we're trying to work out ways to address that, and it's a complex issue, but again, I think what we've done in having that little discussion is that we've actually critically analysed the way we think about health behaviours, and I want you to keep doing that, because in your assessment you're probably going to suggest as part of your intervention some health behaviour changes or some education. Now we know that education is absolutely vital. Supporting health literacy is a really important nursing role. However, it happens in the context of all of this other complexity, and I want you to consider that when you're writing down, I think, you know, people should eat more vegetables. Be critical of that intervention and how as nurses we actually need to do more than just suggest it as something that would be good to do. Okay, so moving on, because I'm totally running out of time if I don't keep going. So this is something that the social determinants of health, and many of you would have heard of this. Now, please don't get overwhelmed by this slide. It's meant to be overwhelming because the social determinants of health are really complex. And there is some information in your module about that and a couple of videos to just kind of break it down a bit. But what I want to highlight for you is where we sit as nurses. We are in the health system, but everything that comes before, so governance, education, societal values, socioeconomic stuff, education, occupations, everything that comes before manifests itself in the health system. So we are actually operating under the burden, if you like, of social inequalities. And so it's not that we need to fix them all. We can't. We just need to acknowledge that they're there and know that within the health system, we tend to bear that burden, and because those social inequalities manifest themselves in people's health. And as workers who are positioned throughout the health system, it falls to us to actually try and impact those determinants in the way we care for our patients, but also be mindful of them. So I'm not asking you to solve the world's problems at all. I'm just asking you to be mindful of the social determinants of health. So that's why that's in the module. So basically what we end up with is this sort of broader perspective that it's really important as nurses that we consider. So we're not just talking about diseases and what's actually causing them in the person, but we're actually also talking as nurses about the impact of those diseases on the person and their family or their community. And so we need to be thinking more along these lines to inform our person-centred care. So even if diseases do or don't cause each other, there are effects that arise, such as frailty, loss of income, the issues that we as nurses in the health system become presented with. This is what we face with our patients. We're not lab scientists, we're care providers. And so whether or not the diseases are related to each other, that is one part of the picture, which helps inform how we address them. But we need to consider the impact of those diseases on that person's outcomes. So, what are the burdens of multi-morbidity? We can all think of examples from practice. Maybe you could put some into the chat of the people that you've looked after who are experiencing more than one chronic disease. Are there physical burdens, emotional, financial? Are there burdens on them just as individuals, or are these burdens on their families? Or are there burdens on all of us as a society? Have a go, just pop some things in the chat. Tennille said all of the above. Yeah, absolutely. It is all of the above. It's quite a complex picture. What do you see as being the burden for the people you take care of? Yeah, mostly financial, so family burdens. Oh, yep, Kajal said due to healthcare services in some countries. Yeah, so absolutely. It might be around access to healthcare services or the actual burden of having to present that healthcare services. Yeah, family commitments, that's really important. Yep, so young person who's disfigured due to disease or mental health issues. Yeah, so we're talking about impacts on young people as well, the burden of disease for not just for old people. Sorry, I should say the older people amongst us. Gemma says, I see a lot of guilt from family members when they're unable to cope with patients with comorbidities. Absolutely. So yeah, we're trying to look after each other. And impacts on self-management support. So yeah, so what we're considering when we're providing care, we're not just thinking about how these diseases work, we're thinking about how they affect the people and communities where we live and work. Yeah, and burden on health system, Leanne said. So yeah, absolutely. So this moves us on to thinking about quality of life. So quality of life is a very important concept in chronic care nursing because people are living longer and the quality of that life is important. It's as simple as that. So as nurses, that's also an aspect of care that we need to consider. Not just are we treating the disease, but is it worth it for this person? Are they living a life that they actually want to live? And can they cope with it? So quality of life, I've got up there, it's basically defined as the degree to which a person enjoys the important possibilities of his or her life. Now, you might have a different way of thinking about it, but that's kind of an accepted definition. And the health-related quality of life reflects the contribution of disease to the patient's sense of well-being, including their physical and mental well-being. And so health-related quality of life is something that's actually sort of able to be measured, and we're increasingly looking at the ways that chronic diseases and the symptoms sort of interfere with work, family roles, socialisation and activities of daily living. And the literature does suggest that people living with severe chronic disease frequently experience things like fatigue, depression, anxiety, social withdrawal and fear. And so if you think about the way those things might impact someone's quality of life, they become quite important aspects that as nurses we need to acknowledge and address. And obviously chronic diseases can lead to functional decline, so what we're actually able to do. So it's important to also remember that multimorbidity is generally not experienced in isolation, and we've touched on this a little bit in the chat. And so it's really important to consider the role of families, and not to make assumptions about who families are, but there might be significant others that are important to the person. There is a burden on families associated with chronic diseases, their time, the practical support that they provide, supporting activities of daily living, emotional burden. So when we're addressing multimorbidity amongst our patients, we do need to think about carers and families. They can experience anxiety, they can have poor health literacy, they can struggle with complex appointments and caregiver burden. And so I really encourage you to consider this also in your interventions. What are we doing to empower the people that actually do most of the work for us? And if we can think about that, then we're actually going a long way in really doing great nursing interventions. Now this slide here will be actually familiar to those of you who have done NSN007. This is about the sort of focus on chronic disease management, and where we are now when we're talking about multimorbidity is we're in the blue dotted section. So the aims of our interventions as nurses really are to interrupt, prevent or minimise the progress of a disease at an early stage, and focus on halting the progression of the damage that's been done and reduce the development of additional complications such as comorbid disease. So that's just a little reminder of where we're at. Primary prevention is around reducing the likelihood that a disease develops in the first place, but in this unit we're talking about people who are living with complex comorbidity. So slowing the progress of a chronic disease. Most chronic diseases tend to progress through different stages that gradually lead to reduced target organ function, declining ability to achieve homeostasis, and increased complications across physical, mental and emotional and social aspects. And so the aim of healthcare is to stop or slow this progression. And so when we think about that, we also need to think about quality of life. So the aim of care is to also optimise quality of life. And that includes the impact on families and caregivers, and strengthen resources to actually manage or self-manage. So, slightly different focus now. We're actually talking about the challenges of multimorbidity, and we're going to reflect on all the different areas where people living with morbidity actually have to turn up in terms of their health care appointments or the services that they need. And so I'm interested to know can you think of a complex patient, perhaps from your own setting, and tell me how many of those which are on my slide now would they have visited, say, in a year? Give me, maybe put a number in there. Was it like 1, 2, 5, Rachel said? Yep, 5, 5, yep, 6, yep. Feel free to put in that chat box any that I've missed too, because I know that that's probably not the only, to be honest, that graphic only lets you have 7 slices. So I probably just put the top 7. If you can think of another one, add it in. But yeah, so we're talking about a lot of different healthcare settings, whether it's in the home, aged care, in the emergency room, and we, in this little group here, we are actually positioned across most of those. And so when you think about our combined potential for impact, it's really high. Because people with multimorbidity are actually really vulnerable to suboptimal quality care. And it's really relates to having to turn up to so many different environments and having clinicians kind of say, oh, that's not my field, I'm going to refer you over there and you can talk about that with that person. And so the burden really becomes on that person and their family to navigate that. And that's actually a full-time job for a lot of people. So addressing the issues related to complex chronic conditions requires reorientation of healthcare systems. And this is actually a slide from NSN007. So if you've done that particular course, you would have seen this before, or that unit. And so what we have here is, in Australia particularly, we do tend to have quite an acute care focused health system. It tends to be a little bit fragmented because we tend to, it's quite disease centred and doctor centred. So we're sort of divided by specialists throughout our healthcare system, sort of focusing on individual diseases and kind of reacting to symptoms and doing that in short bursts or episodic care, which focuses on cure with less attention to what actually goes on in the long term. And so we're very good at diagnosing things, but then perhaps not so good at sort of following through with the actual thorough care. And so what a chronic care model does is it reorientates that way of thinking to be more person-centred, more team-centred, having more of a population health approach with a primary care emphasis. We talk about being proactive, actually planning interventions to preempt what could happen to people and actually trying to prevent sort of bad things from happening rather than sort of reacting once they do. Providing ongoing care options, so referrals for long-term care, not just saying, okay, you're done in our clinic now, off you go. And really on that collaborating across settings. So putting the onus on the health professionals to actually organise themselves together rather than making the person do all of that heavy lifting themselves. And so, look, this is a lot easier said than done, but I've put a little smiley face on the chronic care model just to remind you all that when we're doing our assessment and we're talking about our 2 diseases in our case study, if I see lots of stuff that's happening in that right-hand column, I'll be super excited. So this is, I think, somewhat of a sort of a controversial slide, and it's about evidence which exists, which suggests what nurses in Australia tend to be like, if you like. Now, I inherited this slide when I took over this unit, and I went, oh, come on, give us a break. But I'd be really interested to know what you think, because as I critically reflect on my career, I can relate to some of this stuff. And so maybe if you want to put in the chat, do you think some of that's true? Any of that's true around the way nurses in a practice, and maybe in your own setting particularly? Yeah, Rachel said, unfortunately, yes. Yeah, and so has Kajal and Leanne. A lot of it's true. So yeah, maybe not all, but a lot, yeah. So I think what we are, yeah, sometimes it's the age. Yeah, definitely. And Chloe said definitely in the emergency department. Yeah, absolutely. And I think, yeah, Rachel said time restraints. Absolutely. Time restraints are a huge thing that impact our practice. And so I guess I kept that slide because I thought, yeah, it's really good to critically reflect and go, what is it like about our health system and our position within it and our education as nurses, where we've come from and the way we've been taught to do things that makes us have this more acute care focus in our practice. What is it about ourselves and our practice that needs to change if we are to truly address this huge public health issue, which is already upon us? And so I guess for me, the bottom line there, that we tend not to be involved in policy development, debate and public discourse, that I think is 100% true. And it's really unfortunate because what I keep saying is we could address this problem if nurses were appreciated and actually had a bigger voice. So I'll get off my soapbox now, but I really encourage you all to think critically about that slide. So I want to move on to talk about how awesome we are. And so we, as nurses, actually are proactive and responsive to changes in our patients, changes in their therapy, what is needed to support self-management, and the changing social circumstances of the patients that we look after. And so I think above many other disciplines, this is where we are actually really good. We're on the front line and we're watching this stuff and we know our patients. So I think we need to really work with our strengths. We are really good at this stuff. So this is like generally a slide which sort of talks about some of the ways nurses contribute to chronic disease management. And so I'm really interested to know from you, if you look at those different things or like types of ways of doing care, I guess you could call them, you know, is there something you can relate to in your practice? Do you do referrals? Do you coordinate? Do you act as an advocate for your patients? Feel free to pop stuff in the chat if you're looking at that and going, yes, I do all of those. Leanne said advocacy is really important. Yeah. And Gemma thinks nurses need more resources to give to patients' education. I agree. Yep. Education is critical. Yep. A lot of patients will only take doctor's advice. And you know what? That's the health system that we are in. And we need to change that as nurses. Yep. Referrals. Yep. Coordination and education. Yeah. Just for a little, and Ziki said, yes, education is really important. Yeah. So we know this stuff. Oh, just to let you know, I wrote down what modulating was because I could never remember. Basically, it's changing or adjusting therapies. So we might give advice, particularly nurse practitioners, but, you know, we might give advice around, you know, with diabetes, you need to start monitoring your glucose more often. So we're modulating, we're suggesting how to modulate therapies. That's what that means. And yeah, so we're referring and advocating, and often those two things go together. So really, when you're when you're looking at your assessments, go back to that slide and think about those things in terms of nursing interventions, because those things, I want you to consider where does treatment sit in there? And I think for me, the answer is it sits in all of them. So each one of those, treatment is part of that. Treatment's going to be part of that picture. But the beauty of nursing is we're doing all this stuff to make sure treatments actually work, and they're actually acceptable to the people who are supposed to be taking them. And so it's not without its challenges, but we're the ones doing that work. So we need to really sort of congratulate ourselves, I guess, and keep doing it, because this is what makes nursing so good at actually dealing with complex comorbidity. So with that in mind, I'm going to give you an example now of how 3 nurses, nurse practitioners here in Brisbane, got together and decided they were going to make a change to address issues for people living with multimorbidity here in Brisbane. And so the picture that you can see on the slide at the moment, that's actually what I'd call a revolving door, where people get admitted to this healthcare facility, and then they get discharged, and then they get readmitted, and then they get discharged, and then they get readmitted. So those of you who work in emergency, I think you can probably relate to this, and even some of you who work in acute care. And this is unfortunately the reality for many people living with complex comorbidity, is that they just can't, we're all about supporting self-management, but we're making them go on this complex journey with healthcare facilities or services. So what happened in Brisbane was, and with that might not just be treatments, that might be scans, diagnosis, specialist opinions, going for more tests, picking up medications, going to see another specialist. So it's like a constant battle of just health service navigation. And so these 3 nurses here in Brisbane, I've got the slide here, is actually an article that was published about it. That article is at the end of module 3, if you want to look at that and read it. I haven't included it in module 1 because the module 3 is about complex integrated healthcare services, so I put it there. But I'm introducing it to you now as just kind of an example. And so 3 nurse practitioners in South Brisbane were all working in our isolation. There was one in heart failure, one in diabetes, and one in chronic kidney disease. And so this study is really, this paper is around how these 3 nurses actually got together and tried to do something that was far more focused on the patient than the disease. And what they did, they realised that there was a group of patients that at least 2 of them were seeing. So they were actually seeing the same people in the heart disease clinic, the diabetes clinic, and the chronic kidney disease clinic. So that was where this sort of stemmed from, this study that they did, or pilot, I should say. And this was all in the context of Logan, which, if any of you are from Brisbane, you might be familiar with Logan. It's a really young place. There's lots of young people there, lots of families, lots of different cultures, lots of diversity in Logan, but probably a lower socioeconomic area of Brisbane, and a huge area of Brisbane. Yeah. So that's where this was. Apparently there are 122 different languages spoken in the Logan area. That's reflective of many places in Australia. So what did these nurse practitioners do? They basically organised a, I'll just go, yeah, this is what they did. This green section in the middle, that's the Integrated Chronic Disease Nurse Practitioner Clinic. And so what they did was they identified people who were living with chronic kidney disease, heart failure, or diabetes, and then they were actually referred via their team to the nurse practitioner clinic. They came in to the nurse practitioner clinic, and if they were living with more than one of those conditions. And then what they did was they actually kept the nurse practitioner either kept going with their care, so arranged either 3-monthly or 6-monthly appointments for them, discharged them to their GP if they didn't need further specialist care, referred them back to their medical specialist if they actually did need some particular type of medical care and something changed, or they transferred them back to a sole nurse practitioner clinic, so for one disease focus. And so essentially what they did in that model of care was they actually captured a whole bunch of people who were actually going to many different specialists, and they actually integrated the care so that these people were actually turning up to this nurse practitioner clinic initially for an assessment, and then once every 3 or 6 months, and they actually cut out a bunch of the actual other appointments that they needed. So they took over the care and just said, we're going to manage it. We're only going to send you places if you need something. And so the lady the professor who had this unit before me, this was her project. So Leanne, you asked how long the pilot program ran. I'm going to have to find out for you because I don't actually know. It's still going. But this was her baby. So I'm trying to explain it as best I can. But what they did was that they actually, once the patients were in this combined nurse practitioner clinic, they had a comprehensive assessment and care planning. They had patient education based on a self-management model, so things like lifestyle modifications and treatment adherence, and that was ongoing because they were having multiple appointments. It wasn't just a one-off education. They did regular medication reviews, so they were able to do prescribing and titrating of medications. They did lots of telephone follow-ups and reviews to see how things were going, and they did healthcare coordination, and so they communicated with the specialists, they communicated with the GPs, and they actually coordinated the amount of appointments that people had to have with different those different providers. And so I guess what I'm trying to get at is that it was integrated, so that the onus were those nurse practitioners used their full scope of practice to actually make life easier for these patients. So the outcomes of that pilot were really that nurse practitioners were really cost effective for the healthcare system. And we'll talk about this more in Module 3. I'm just sort of giving you a taster here. But their involvement in patient-centred care improved patients' health outcomes, their knowledge of their disease, their satisfaction with the service provided, and their own self-management of their disease. And internationally, it's been actually proven that patients are very satisfied with nurse practitioner care. And so I guess nurse practitioners are just one type of provider, nursing provider. But I think we can learn from what they did, some of the things that they did in that model as an example that we can all do, no matter what practice setting we're in. And so really the crux of it is person-centred care. And I know you've all heard of this, but again, this is something that I want to see shining through. And so person-centred care means putting people at the forefront and centre of their own healthcare. People become active partners in managing their healthcare to co-determine priorities and plan preferred approaches with their health workers. Patients improve or maintain their health in relation to their own self-identified needs, challenges and goals. And when we get into module 2, we'll talk about this a lot more, identifying patients' own self-identified needs, challenges and goals. And then person-centred care occurs through collaboration with the vision of care being negotiated between health workers and the patient. Okay, so I'm probably not telling you stuff that you don't already know with person-centred care, but it is really, if we reflect back on all of those complexities that we've talked about around social determinants, behavioural determinants, health service access, the way to address those complexities realistically is actually to make the care person-centred, because we can't address all of those complexities. But if we know what's important to the person we're providing care for, then we can actually focus on the complexities that need to be addressed for them. So I have to keep going back to my notes so I don't lose my track. So these are the 8 dimensions of person-centred care. And so they are around recognising the person's preference, providing emotional support, addressing physical comfort, providing information and education, continuity of care, coordination of care, access to care, and thinking about family and friends. So if anyone's sort of reflecting at the moment, I would encourage you to just pop into the chat if you think that you already do a bunch of that stuff in your practice, or if you've seen examples of that sort of stuff being done well. So in your practice setting, for example, how would you perhaps incorporate like personal preferences, or how would you provide emotional support? And again, I'm not saying that we need to live these people's lives for them or solve their complex problems, but the way we address care being person-centred will impact the effectiveness of the care that we provide. So is anyone willing to is there anything you've done to improve access to care or to involve family and friends? I think for myself, sometimes, although we are super time limited a lot of the time when working in oncology outpatients, quite often you've got to sit with people for a while you give a treatment. So just listening was actually really important for sort of emotional care. Like I didn't really do anything extra, but while I was sitting there, I'd let them talk. Yeah, personal preferences, Gemma said. In England, we have the This Is Me form for all dementia patients to allow all healthcare professionals to know patients' likes and wants. That's fantastic. So I assume that's some sort of form where you actually record information about that person, and so that informs who they were and their profession and their preferences. Yeah, so that is a really fantastic example of a nursing intervention that is person-centred. Yep, and Antoinette said giving them all the information so that they can make an informed choice. Yeah, absolutely. Kajal has said information and education In India, we have to give education to the family and patient regarding the condition as part of person-centred care. Yep, so again, education, really important. And Ziki or Thea, who I believe is from China, has said help the patient build up the confidence to overcome the disease. So I guess in terms of self-management, confidence is really key. Yeah. Antoinette, having open disclosure. Yeah, so do you mean, so you actually, by disclosure, do you mean disclosing all the kind of care that you're giving, or like so that the person's informed about what's actually going on? So not just doing stuff without asking. I wonder if that's what you mean. But I guess what I'm asking you to do with reflecting on this slide is really just to think about how we are doing person-centred care. So this, I was debating whether or not to include this slide, because I thought, well, why are we getting confused over whether it's patient-centred or whether it's person-focused or person-centred? Noria's said in their home visits to educate the family, which is great. That's a really good example of person-centred care, is actually going to them. Oh, and Antoinette's clarified around open disclosure being informing all parties involved with residents about care or incidents that occur. Yeah, okay, so actually involving them in the decisions and actually not shutting them out. Yep. So, so reflecting on this slide, again, this is one where it just challenges us to be really critical in our approach. Tennille said her system in aged care is being able to be viewed by family from home so they can see what's happening in real time. Wow. Yeah, so, I mean, gee, that's actually controversial, but I can see why places might do that. Yeah, so we've got patient-centred care here on this slide in the left-hand side, is really about a little bit still about that disease focus around focusing on body systems, diagnoses, episodes of care, and sort of interactions with the healthcare. And then person-focused or person-centred care is sort of actually looking at episodes as part of a life course experience with health. So understanding people's experience of health, considering morbidity or multi-morbidity as combinations of types of illnesses, viewing body systems as interrelated, using coding systems that don't just reflect diagnoses but actually allow for specification of people's health concerns, so what matters to them, and actually integrating and considering the sort of lived experience of health and illness rather than just disease that needs to be fixed. And so have a reflect on that slide. What it's doing is encouraging critical thinking about the care that we provide. And then this last one, this is actually a really old article, but again, I inherited this slide and I thought, oh, will I include that? I don't know. But what it actually does is it reflects on three sort of models or ways of thinking about care. And so the first is on the left is the paternalistic model, which is where the sort of the doctor or the medical professional owns the expertise, whereas the informed model on the right-hand side is where the person living with the disease owns the expertise. And so however they've found out that expertise, they may, well, they live with it. So they are actually experts. And so what we talk about with a shared model is actually acknowledging that there is expertise on both sides. So we need to acknowledge that as medical professionals, we do have education and we do know what we're talking about, but we also need to acknowledge that patients also have experiences and they know what they're talking about too. So it's like a two-way street. Acknowledge that we are not the only place that they're getting information from. And so I left that slide in because I thought, you know, it was again encouraging us to think critically. And so finally, just a final reflection, people living with chronic disease multimorbidity do require health service delivery to be reorientated. Clinicians need to develop flexible service delivery models. We need to move away from inflexible silos of specialty structures. And improved communication and collaboration across multiple specialties and relevant team members is really important. So before I just talk, and Tanil clarified, she's not talking about camera views in the nursing home, she's talking about progress and GP notes, for example. Yeah, and that makes perfect sense to include families of vulnerable people who are in residential aged care, to actually include families and know what's going on. And so is there any more, does anyone want to type anything in the chat? I'll certainly come back to it. I just wanted to quickly talk briefly about assessment 1. In this, before I do, this module, this seminar, I haven't talked about absolutely everything that's in the module. I've just given you some things to critically reflect on as you work through the module. As you read through those materials, I encourage you to reflect on your own practice and pick up the bits of information that are really relevant for you and your learning. And I think if you can do that and apply some of those contexts that you're working in to what's in the module, then that will really help you with assessment 1, just to sort of make sense of it. Our assessment, as I said before, it draws on module 1. Your next, the next seminar that I'll deliver is in week 4, which is actually before the assessment's due. So we will have the opportunity to talk more about it at that stage once you've had more time to think. What I really want to see, submitting someone. So assessment 1, you need to select one of those chronic diseases and then add another one to that, which coexists. If you work in a specialty type area where you see people who are living with something completely different that's not on that list, very happy for you to work with that in your assessment. Just let me know, perhaps by email, so we can make sure that you're on the right track. It's all about a review of the evidence. And so I really want to see you critically reflecting on the evidence around the comorbidity of those 2 diseases and nursing care. So really want to see you applying some of the concepts that we've talked about today, and thinking about how, as nurses, we deliver interventions that are really about addressing person-centred care or about supporting self-management. As I said in the videos around the assessments, just describing a treatment is not really being critical of the nursing role. When I say being critical, I don't mean criticising, I'm saying critically reflecting on what it is that nurses do that goes beyond just a treatment. Really important, if you when you're submitting your assessments, try not to submit after 10 p.m, even though there's a midnight cutoff. From what I'm told, there can occasionally be glitches and it's really hard to get help at that time of night. And you might just need to submit a couple of times to make it work. So give yourself some time to do that so you're not stressing. The Turnitin system can be busy because everybody's submitting at midnight. That's a QUT thing. There is a question and answer Padlet on Blackboard about assessments. I encourage you to post your questions in there because they will help other people and they'll also help my workload. Chloe's asked, are you marking our assessments or will they be marked by an MP CNC who works within chronic care? I'll probably be marking most of them. I may need relief depending on the amount of students who end up in this unit. But we have sessional academics who work across the postgraduate units here at QUT, and we do marking moderation. So we have a fair process around marking where it's not just me who gets to decide, it's actually sort of collaborative where we moderate. So I hope that helps answer your question. As I was saying about Padlet, if you put a topic heading for Padlet, it helps other people because other people can actually respond to your questions. You're welcome to respond to each other. But if you put a topic heading, then it's easier to sort of see who's responding to who. You do have the option on Turnitin to submit a draft. I don't have to see it, but it's an opportunity. If you've never used Turnitin before, it actually generates a report which tells you what percentage of your essay is an exact match for some other text that's written elsewhere. And sometimes it's really good to have that report because if you get that and then you go, oh, it turns out, this whole paragraph is actually straight from a journal article, I need to rephrase that and get rid of that. So you can actually submit more than once. And what will be marked is your final submission before the due date. And as I said in the video about the assessment, government reports and websites are okay to inform some of your assessment, but I don't want to see a whole reference list full of government reports and websites. I want to see peer-reviewed literature. And if you're not sure how to go about finding that and reviewing that, then I would suggest you book into one of the sessions or talk to the library, look at the learning resources that I've posted because they're really good to help you do that. What is an acceptable similarity percentage? Or it's something like, it sort of depends if you have a cover note. Usually if you've got like a cover page, you'll end up with about 10% anyway, but it comes up with all these, you'd have to see it, but it comes up with, you might have a line here and a line there and a line there, that's acceptable. But if you have a whole paragraph, that's not acceptable. And so that's what we're looking for, particularly if that doesn't have a reference at the end of it. Yeah, it's highlighted. So you sort of have to have a go to see what pops out. Yeah. Happy for you to use headings and subheadings. And please do yourselves a favour and avoid Google if you can. It's not the best search engine. The library database is a much better search engine for peer-reviewed literature. Start putting words on the page early. Because the quicker you just write down ideas, even if it's just dot points, then you can start to refine what you've written into a really nice essay. And so look at my resources that I've posted in assessment 1 around what it means to be descriptive versus critical, because that's really important. And then 1 or 2 last slides before we go. Oh, what is the number of references to be used? I don't mind. There isn't a set number. I want the evidence that you include in your essay to be relevant to what you're talking about. And if you can form a really strong argument of why, 2 or 3 interventions are really important based on 5 articles, great. If it takes you 20 articles, great. I don't mind. I just want the evidence that you use to be good quality and relevant. Now, this is my little bugbear around use of terminology and language. So some terms are used interchangeably throughout the literature, and I'll do it myself. And that's totally fine. But when you're writing your own essay, I'd ask you to try and be consistent. So things like chronic condition, chronic disease, chronic illness. Use one and stick with it. Same with comorbidity, multimorbidity, and person, patient, or client-centred care. I don't really mind what you call it. Just make sure you're consistent. And yes, someone's posted in the chat, QUT uses APA. Yes, QUT uses APA referencing, and there's a super easy guide on the QUT library website. It's called SiteRite. If someone can type that into the chat, it's CITE right, yeah, WRITE, yep, CITE/WRITE, yep, and that's where you find your guide on how to do referencing. And it's literally just if you've got this type of reference, you do it this way. So it's not rocket science. It'd be really great if you could look at that. And then just with use of language and terminology, if you can, in your writing, try to avoid emotive language. So we tend to say a lot, oh, people are suffering from something. That's a subjective way of being. I would rather you said neutrally, use neutral language and say that, say instead of Mary is suffering from hypertension, Mary is experiencing or living with hypertension. Unless Mary has walked up to you and said, I am really suffering, it's better to use neutral language because that may not be the case that she's actually suffering. Avoid labelling people, and I know that you won't do this, but we do, sometimes we use language like, oh, diabetics or epileptics. What I would rather you do is use people living with diabetes. So this is all about being person-centred. The person comes first, not the disease. The disease is just an aspect of their experience, but it is not them. They are not that disease. So that if you could avoid labelling, that would be great. And avoid assumptions, judgments, and stereotyping. And so something like old people lose their memory, well, it may be true, but you need to base that on evidence if you're going to make a statement like that. So, for example, older people who are living with dementia can experience memory loss. Reference. That's perfectly acceptable. It's based on evidence. It's not just a stereotype. And I think this kind of way of thinking, which is reflected in our writing, is really critical to being person-centred nurses. Poor Chin's asked, do we have to use APA 7 or APA 6 would be fine? Either. Honestly, I'm probably not going to stress too much. APA 7, the main difference is around putting an insight reference for everything, in-text reference for everything. I don't really want, page number. Sorry, a page number on every in-text reference. I don't really need a page number for everything. I'm happy for you to just put the in-text reference. So yeah, APA 6 or 7 is fine. That's it. I'm going to stop the meeting now. So I encourage you to get in touch. I encourage you to put your details on the Padlet. If anyone's got any final questions, just post them in the chat now. But otherwise, I'll see you in a few weeks' time. Thanks, Leanne. Thanks, everyone. Okay. Bye, everyone.